Well, hello everyone. This is Dr. Amigues, your friendly rheumatologist and host of the Unabridged MD podcast. And today, I think you're absolutely going to adore my guest, our guest. You're going to see, we're going to learn so much about perimenopause, menopause, and how it's linked to joint health. Without further ado, I'm going to get Dr. Block coming here, introducing him and sharing how he is doing what he's doing right now. Dr. Block, thank you so much for coming on the show.
Oh, Dr. Amigues, it's such a pleasure to be here. Thank you so much for having me. All right, well, a little bit about myself. I'm a 38-year-old male. I never really thought I was going to end up in the midlife women's health realm. But as we live life, we all kind of have our interesting journeys and stories. One of the things that I have found about myself professionally is that I get such great satisfaction in helping patients that are underserved, but not necessarily in the way that you would think. It doesn't have a lot to do with socioeconomic status. It doesn't, whether or not you've got good insurance or not. It's about taking care of populations that have unique needs that we're not all ubiquitously trained to take care of. So one of my passions, originally is LGBTQ health, because this is a population of patient where a lot of times sexuality and gender identity are not well understood or trained in the professional side. People forget that we're humans as well. And so sometimes we just have our journey where it's harder to learn things or experience things. And my husband, as a nurse practitioner, the two of us care a lot about this population, making sure that everybody deserves good access to excellent healthcare, not just the common things. Along our journey, I've been in a traditional health network practice. After the pandemic, I got a little overwhelmed. I had been working in the public health space and teaching academics in my family medicine residency and all of these really cool programs. And then with the pandemic, it just became too much. I needed to step back for a little bit. And that's how I ended up in urgent care for about 2 years. And that was really fun because I realized all of the fun things of family medicine that I like when people are acutely sick or have injured themselves or cut something open that shouldn't have been cut open. A lot of times in traditional practice, in primary care, we have difficulty accessing appointments for these patients because we're filled with a lot of the chronic care. Over time, however, I found that it was just not everything that I needed it to be. And my husband, John, in primary care, we realized that we wanted to go along our own path. And so we met with this incredible company called Miss Medicine that one of our friends, Dr. Nick Davis out of Dayton, Ohio, has been working with for a couple of years. They are a company that want to help start concierge medicine practices because they believe in the autonomy of being able to run a private practice and not having to answer to anybody else. One of their main goals, however, is they are really passionate about midlife women's care. Dr. Lisa Larkin, who is the brilliant internist that started this group, her main mission is to really help educate providers, physicians and all of the APPs to really take care of women in this underserved population. On average, as I'm not sure what you remember from your training there specifically, we get about 3 hours in the American medical school on menopause. It's not much. And then with everything else that we deal with in primary care, because our field is so broad, it's a lot of times it's pushed to the side. And I've started working with these patients in practice because they were in desperate need. But I didn't have an opportunity to really have a formal education, and was kind of flying by the seat of my pants to help these patients because, quality of life is so important for me. One of the things that Miss Medicine asks when we start our practices is that we become actually menopause certified so that we can actually start to help this population.
And so, just to stop you a little bit here, and thank you so much for your introduction. And it makes so much sense now that you're in this field. When you say, well, women that are menopause are in dire needs of help, and clearly, like currently at least, physicians like me and you, like our generation, has not learned a lot unless we actually decided that we wanted to learn more, like you did and like you are. What type of symptoms are they coming with? Like, what's the issue? Like, I was just talking to my friend, my good friend from when we were like 15 years old, and she was like, well, this is what's happening. No. I guess I'm just going to wait until it passes. And I'm like, but we have treatments. Like, what are you doing? We can do something. What are they complaining to you?
Yeah, well, and the spectrum is broad. If you live long enough, 100% of women will go into menopause. It's just going to happen. That's a normal life process. But I have seen it in so many different ways because every individual has a unique experience. Sometimes people are coming with sleeping problems. All of a sudden, they're not getting good quality sleep. They're up all night. They're going to the bathroom. In the perimenopausal space, a lot of times some of the first signs or symptoms that they're going through, a life change is that their periods become a little bit irregular. And that has a lot to do with the changing reserve of the follicles in the ovaries, because that's actually what creates estrogen. Some women have terrible mood shifts. We see history of dysphoria. If you've had depression before, that's your number one predictor for having it in menopause. But sometimes it's that fluctuation in hormones that all of a sudden makes, somebody feel really unwell. Sometimes we'll also see this in just unexpected weight gain. All of a sudden, somebody, a woman's coming in with 20 pounds of weight gain, and she, has energy issues, or her appetite has changed. All of those things can all add up. But sometimes it's just, maybe I must not be eating well or exercising enough. There can be a lot of things where they slide in all of a sudden, and the quality of life goes down. Just because you enter menopause doesn't necessarily mean that you need any treatment at all. Some women skate through and they make the change and they do really well. But the sad thing is that we spend so much time learning about how to treat, in early female reproductive years and really focusing on pregnancy. But then we just kind of drop the ball when it comes to women in another phase of their life, which is why so many women, believe that all they have to do is just kind of suffer through it.
Yeah.
This can be a long time.
Yeah, and I see that in my practice. What's funny is that I don't think I was asking those questions before. And now realizing that, UTIs are not, infection, for our listeners, or urinary tract infections are not necessarily related to the immunosuppression that I may not even give them, and then they would have like recurrent UTIs, and then you realize that they were not taking any sort of estrogen there. Since they are menopause. There is also something, I don't know, you have to tell me if it's real. So I saw it on social media, so I don't know if I can trust it. Yeah, exactly, right? There is a sign called not feeling like myself. Did you guys learn that? Is that real? Not feeling like myself? Because it definitely, I'm postmenopausal because I had to remove my ovaries due to a BRCA positive, but I mean, at first I think, yeah, that was true. I didn't feel like myself, but I don't know that I could have called this term.
Yeah. Well, and it's something, no, I was not taught that.
It's probably just social media.
No, but I mean, but it's such a true thing. Social media does have some benefits in terms of helping with awareness, but yeah, think of it. You wake up, in the last couple of years and things have been on cruise control, and then you wake up and you're like, my energy sucks today. And then it kind of just continues that way. And, granted, when it comes to energy or fatigue or joint pain, when we talk about, what a differential is or coming up with all of the possibilities, none of these symptoms are clear.
Yeah.
But it's enough to identify knowing yourself, knowing your typical body functions or what feels right, and then knowing when you don't feel right. in primary care in general too, especially in modern healthcare. And part of the reason why I also was so interested in moving into a concierge medicine space, my average time is an hour with a patient. If you come in and we're doing a blood pressure check and I have all of my metrics, to get satisfied for the health network or for the insurance company, I'm probably not going to spend as much time asking, how are things? How are you feeling? And if you don't feel well, and sometimes we get so lost in the, churning of just the work that we need to do, we forget about the work that we should be doing, which has to do with quality. And quality is just as important as quantity.
Oh, I'm so on board with you. And it's really funny when I'm finding myself, I find myself telling my patients, hey, no, sexual life is important. Like, don't just like, oh, this is done because it's so dry. I'm like, but we have treatments. I'm not a specialist, but we do have treatment. So call to action here for everyone that's listening. If you're going from perimenopause or menopause, please don't seek help to people who are like Dr. Block specialists, because you don't have to suffer, honestly. Dr. Block, talking about joint health now when it comes to menopause, can you tell us, can you educate us about how it looks like, and if treatment can help? What kind of treatment can help, maybe?
Sure. Well, and joint pain, just kind of like we talked about fatigue, and especially as a rheumatologist, so many things, the differential, the causes can be so great. And that's why it takes a lot of good detective work. But, not surprisingly, more than 50% of the population is going to experience joint pain at some point of their life, usually more as we age from, the wear and tear. We've found that more than 50%, though, in the female population as we age are going to experience joint pain. And so some of the really interesting things about, when I've really started to dive into some more of the hormonal contribution to joint pain is that we have estrogen receptors, males and females, in our parts of our bone, in our synovium, which is the lining of joints that make fluid. We have it in our tendons. And so when we see that there are direct receptors that activate to, estrogen, we started to study it a little bit more, and we can see that it actually has a lot to do with encouraging bones to build and, increase their density, have a lot to do with, flexibility and strength of the connective tissue and the muscles. And we see that in perimenopause and menopause, that women almost have twice the rate of pain in terms of rating. Now, is it always menopause that leads to the joint pain? No. And then understanding, what's going around the joint pain. So is it a myalgia? Is it a pain that's related to the muscle around the joint? Is it a tendon related issue? Is it the bone itself? And what we've also found, there's not a direct correlation between menopause and fibromyalgia, but during that period of time, there's a lot of biopsychosocial stressors. So you have the biggest biological factor is that in menopause and perimenopause, it's not the low estrogen by itself that causes the symptoms, it's the highs and the lows. So it's actually fluctuating up and down that make it such a difficult journey for so many. And that can be also the source for some of the joint pain. It's not ever recommended that we start throwing hormones just a joint pain, because like I tell all of my patients, everything that we do and everything that we don't do in medicine, it always comes with a consequence. It's kind of like going back to Harry Potter and magic, right? There's always a consequence with it. And so as long as we know what those consequences are and we can be prepared for it, that's really important. So with joint pain, a lot of times, from a family medicine point of view, I want to make sure that the joint itself looks okay. Do we need to consider some imaging to look at the bones? I do an actual joint exam to make sure it moves well. And test the ligaments and the tendons and the strength. But if we've gone through a lot of that and symptoms seem to be related along the menopausal spectrum or perimenopause, and there are other reasons to consider hormone therapy, we've actually found that when women receive this therapy, a lot of times it can actually make an impact on joint pain. We've even seen from some MRI studies that women who have had their ovaries removed and lose that estrogen source can actually make their cartilage a little bit more brittle and firm. And that with replacing with estrogen, it can actually soften and hydrate that cartilage again.
That's helpful. This is really, really helpful. When you have, I guess I have this question of, I think that very often women don't necessarily realize that they are going through perimenopause. How do you approach a woman that it's in, I'm assuming it starts like around in the early 40s, maybe mid 40s. How do you approach women that are of that age to kind of discuss those issues?
Right. And it's important that's where preventative medicine also helps us there. Not everyone, if it's not coming to mind as to, nothing really hurts, I feel great, life's great, I don't need to see the doctor. Well, when you're young enough, you can get away with it. But as we age, a lot of the work that we do in preventative medicine and good primary care is starting to screen for those things. So as a family physician, when you come in, believe it or not, I'm going to talk to you about your exercise, even if your weight is normal and you have good muscle mass. I'm going to still check your blood pressure if you're not having headaches or chest pain. I want to know about your diet. I want to know about sleep. And to the surprise of a lot of my patients, I want to know about your sexual function.
Mm-hmm.
A lot of people are very shy or embarrassed, and I think it's probably just based on societal views. But behind closed doors, most of us are very sexual creatures, and so it's nothing to be embarrassed about. And if you notice any changes of those functions, or if anyone starts to say, I'm going to the gym, but my knees are hurting a lot more, or I have this 10-15 pounds that all of a sudden I've put on, I can't get it off. Or asking about, especially from a gynecologic point of view, regularity of periods, and are you getting your proper gynecologic workup as a female patient? Those are all opportunities where, when we are trained in this field of menopause, we're always looking for it, whether it looks like we are or not. And so once we have had the formal training and we have taken care of enough patients, in terms of like menopause certified, practitioners such as myself, it starts to become part of something that I'm always looking for. And if it's not there, then that's okay too. But we want to make sure that nothing exists.
It makes total sense. I think, I like to have call to actions because it's, you can listen to the podcast or watch on YouTube this podcast and think like, okay, those are great people talking to each other. Or you can be like, well, I think that to me, the really important thing here is to realize that we're a creature that evolve through time, and that aging is not a condition, aging is not a disease. Being menopause is not a disease, it's not a condition. It's the same thing that when you're going through all those hormonal changes, when you're pregnant, when after pregnancy, and so on. And if you recognize yourself in any of the symptoms that Dr. Block and I were discussing, it is worth talking to your OBGYN, to your family physician, and just starting to prevent further issues. Even just knowledge is power, right? So then you know what you can do, and then you can really decide what you want to do. So, our podcast is named like the name of, so it's On Average MD, Hope Driven by Science. So I really like when our guests share a history of hope. Do you have a history that can bring hope to everyone listening today?
Very much so. And thank you so much for doing that segment. As we were discussing before we started the podcast, it's so important for us to have these patients and these stories because they're not just good for patients, they're really good for the doctors and providers. It's what makes our job so special to us. So I have a lovely gal. She is 51 years old, and she's actually one of my first patients in my practice. She actually tracked me down from the Menopause Society website, which now I am listed as a provider there. So if you want someone specialized in that space, you can actually track us down. She has a history of ductal carcinoma in situ, which means that she had a early contained cancer in the right breast. And she decided to make the tough decision to have a bilateral radical mastectomy, so having both breasts removed just because of the risk. And she, for the last 7 years since then, has been doing okay. But in the last year, she started noticing that she did not feel like herself. She had terrible dysphoria, low mood. She had really difficult energy issues, and she's a very active, fit individual. It was starting to take a toll even on her professional life, which recently was a transition over to behavioral health sciences in the corrections department. So working with really, difficult individuals that need a lot of help there. But it was to the point where it was basically, she felt like her life was taken away from her, not sleeping well. And she had a discussion with her gynecologic nurse practitioner that she established with. And she recognized that this sounds very much like perimenopause, but with the history of cancer diagnosis in the past, end of story. The truth is that looking at the data, that one, it's not always as scary as it sounds. And that two, as providers and physicians, we have to remember that we don't live that experience. So if somebody is so miserable and and this gal's very intelligent and very driven, she knows what some of the risks are with, using hormones. Everything comes with a cost. But she said, I'd rather have, a potential, risk in terms of having a negative outcome, potentially even, another cancer experience than being miserable my entire life. And that's part of the discussion that's really important in the menopausal space too. A lot of women that have had some very difficult life challenges, especially cancers, and how do you navigate that? And what does the science say? And so we actually found a very appropriate medication that is actually being studied right now as a possible treatment for DCIS, the ductal carcinoma in situ. And it uses a medicine called a SERM. So it acts like an estrogen. So sometimes it activates the estrogen receptor and sometimes it blocks it. And we use a lot of them for bone density, but this one has some really cool effects at actually protecting against breast health. And we don't have a whole lot of data in terms of how do we image and follow someone who's had a mastectomy or bilateral mastectomy. And fortunately, within a week, she was feeling like a whole nother person and just so grateful and happy that she could get back to her life. And that was, made all of the work so great to do for her.
That is so wonderful. Thank you. And, I share my own cancer journey for breast cancer. So that is definitely something that I completely understand and I can relate to. Dr. Block, thank you so much for being on the show. And we'll put this in the show notes, but where can people find you? How do they search for you?
Sure. So my office is called the Cove Concierge Medicine. Our website is thecovecm.com. Or searching for Dr. Aaron Block. Usually I've been scattered around the country over my time, but I'm in Castle Rock, Colorado. And we do telehealth, all across the state of Colorado, and I can do it as well in Ohio. So if I can ever be of service to anybody, come find me.
Yes, absolutely. And you'll be lucky. I have been in Dr. Block's office, and it is one of the best, most beautiful office and the most welcoming office I've ever been to, and I've been to quite a bit. Thank you so much, Dr. Block. I'm sure we'll have you, hopefully, if you want to, and if you're willing to, we'll have you again on the show. And then everyone, if you like this episode, share it with a friend, and we will see you next week. Bye, everyone.